Bismillahirrahmanirrahim. Thank you very much for this kind introduction. So, after going through the treatment of hepatitis B, so my task is to discuss about hepatitis D or delta hepatitis. So, for the selection of the patient for treating delta hepatitis, we should have the detectable HDV RNA. There should be elevation of ALT and moderate to severe necroinflammation or at least moderate fibrosis using the standardized scoring system. And for this, we may take the help of FibroScan nowadays. And the initial studies done with the pegylated interferon, we are still using pegylated interferon here. And the experience is that about 1/4 of the patients, about 25% of the patients responds to the pegylated interferon. And this includes one of our studies, population general viral hepatitis. So, what about nucleoside analogs? We frequently prescribe this to our delta hepatitis patients. Monotherapy has no therapeutic value for delta hepatitis, and there are studies that were combination of nucleoside analog in HIDID1, adifovir was added to the pegylated interferon in HIDID2. Tenofovir added to the pegylated interferon, and in our own study, entecavir was added to the pegylated interferon. But all these three studies failed to show any additive value of adding nucleoside analogs. So, what is the role of nucleoside analogs in the setting of delta hepatitis? These drugs are recommended for patients who have the delta virus, but their HBV DNA is persistently elevated more than 2000, or with any level of HBV DNA in patients who have the cirrhosis of liver. In patients of delta hepatitis who have decompensated cirrhosis of liver, we do prescribe nucleoside analogs even if the HBV DNA is not detectable. So whenever we start treatment of delta hepatitis with pegylated interferon, we also give nucleoside analogs because this decreases the risk of HBV flare during delta hepatitis treatment. So going to the newer agents, there is one agent which is the pegylated interferon lambda, and this is a type 3 interferon, and this has got the better value as far as the adverse events is concerned, because type 3 interferon receptors are expressed on the liver cells, and this is a location where the treatment is desirable. And so the side effects are less, and there are studies, ongoing studies with lambda interferon, and this is one of the studies that were done, multi-center trial. Dr. Saeed from Pakistan participated in that. And this study shows that 180 microgram dose of lambda interferon is better than 120 microgram of lambda interferon. But if you combine the results of 120 and 180 microgram, the response rate was not much better than the pegylated interferon alpha, but the side effects were fewer. Elevated bilirubin was observed in some of the patients, and 3 out of 15 patients that were recruited from Pakistan, and they had the elevated bilirubin. So in the next phase studies, Pakistan was dropped from lambda interferon trials. Then we have the new agents, which is bulevirtide, and then these are the entry inhibitors. We have the prenylation inhibitors, which is lonafornib. We heard about nucleic acid polymers and antisense oligonucleotides in the treatment of hepatitis B, and these drugs are also being tried in delta hepatitis. So because most of the drugs that we use in the setting of delta hepatitis fail to eliminate HDV RNA, so what should be the composite endpoint during research for delta hepatitis? So this was the sort of consensus which shows that if there is more than 2 log reduction of HDV RNA along with normalization of ALT, then this may be taken as the surrogate marker for the treatment efficacy. So the new studies follow this endpoint. About the treatment, we should know where these drugs act upon. If you see that HPV DNA, the virus, hepatitis D virus, it recognizes the same receptors as the hepatitis B virus, which is the sodium taurocolate co-transporting peptide, and then this virus enters. So there are drugs, 2 drugs. One is the bulevirtide, which has been now approved by the European agency. Another drug is HS0033. So these drugs prevent the entry. When the hepatitis D virus ribonucleoprotein enters the virus, replication takes place in the nucleus. And from the nucleus, we have HDV genomic RNA, which is released, and hepatitis D antigens that are released. So there is a process which is called prenylation. So if we inhibit the prenylation, which is the modification of the lipid component of the delta antigen, so we have the one enzyme which is called farnesyl transferase. If we inhibit this enzyme, this is the host enzyme, and the drug which is being used is lonafornib, then perhaps we may prevent the formation of any effective D antigen. So this is another drug which is being tried. Then the both things, antigen and viral genome, goes to the endoplasmic reticulum, and in endoplasmic reticulum, HDV particles formation occurs. From endoplasmic reticulum, the particles go to the Golgi apparatus, and in the Golgi apparatus, these particles become covered by surface antigen. So if we prevent the covering of these particles by surface antigen, then we can perhaps prevent the proliferation of the virus. And the drug which is being tried is nucleic acid polymer. From the Golgi apparatus, these are the DV particles that are released, but surface antigen is required for these particles. And if we prevent the surface antigen from entering and from the formation, then we have these small inhibitory RNAs that prevent the formation of surface antigen. If there is less amount of surface antigen, and then we can prevent the formation of effective D viruses. It should be remembered that even if the surface antigen is negative, virus can even survive within the hepatocytes. And these virus particles may proliferate if the patient has been exposed to hepatitis B in the past, because we have the genomic HBV, which is the virus which is incorporated into the genome, and then we have the cccDNA. So even the surface antigen is not there, even then the virus may proliferate. Even the patient has not been exposed to hepatitis B, even then the virus can survive within the hepatocytes if there is infection, and the surface antigen is provided by hepatitis C virus, dengue virus, varicella zoster virus. But this virus will not be able to come out and infect the other cells, because pre-S antigen is required for the entry of the virus into the other hepatocytes. So after this concept, so that first talk is the bulevirtide, which is the viral entry inhibitor. And here, this drug has been approved for treatment of delta hepatitis. And this drug is being tried alone in combination with the pegylated interferon. This is a drug which mimics pre-S1 protein of the hepatitis B surface antigen, and this binds to the sodium taurocolate co-transportive peptide receptors. The drug is administered subcutaneously once a day, 2 milligram dose, And the response, which is the composite response, in the phase 2 and phase 3 studies show that this is about 47% response rate. But in the actual real world experience, this is about 31% composite response rate. This is an ongoing study, and this is the MIR 301 phase 3 study. And this study shows that there were 3 arms. In each arm was about 50 patients. 2 milligram subcutaneous daily was compared with the 10 milligram subcutaneous daily. And in the third group, the treatment was deferred for 48 weeks, and then 10 milligram subcutaneous daily was initiated. We can see and the results for this study, and these are the 48 weeks results that were recently published in New England Journal of Medicine. The patients who received 2 milligram or 10 milligram, they equally responded to the treatment as far as the HDV RNA decline and normalization of ALT is concerned. If you see the composite endpoints of this study, the composite endpoint or primary endpoint was the 48 weeks decrease in HDV RNA, more than 2 log or undetectable HDV RNA, and normalization of ALT. If we can see here that 2 milligram and 10 milligram equally achieved a similar sort of end results, and the response rate was similar, and response rate was better if you continue treatment for 96 weeks as compared to the 48 weeks. Again, this study, there are other parameters that were seen. If we see the undetectable virus, one parameter may be 2 log reduction, other parameter is undetectable virus. So undetectable virus was seen more with 20 milligram with the 10 milligram of bulevirtide as compared to the 2 milligram bulevirtide. But as far as the hepatitis B is concerned, no much effect was seen, beneficial effect of using this bulevirtide drug in delta hepatitis patients. So current consensus is that you start with 2 milligram daily, continue for 24 weeks. If the virus becomes undetectable at 24 weeks, continue treatment for another 24 weeks, and then you may stop. If the virus becomes undetectable at 48 weeks, then you may continue another 24 weeks. If the virus is still there at 48 weeks, or if there is less than 2 log reduction at 24 weeks, add pegylated interferon. So treatment duration with bulevirtide has not been established. This is a similar proposed algorithm for that. Coming to the lonafornib. Lonafornib, as we have seen, prevent the prenylation of the viral receptors of delta antigen. And this is a drug that was initially used in higher doses, 200 milligram twice a day and 100 milligram twice a day. But there were a lot of side effects. But later on, ritonavir was added to boost up the response, and the dose of the lonafornib, which is farnesyl transferase inhibitor, was decreased to 50 milligram twice a day per day. As we can see, lonafornib with ritonavir achieved the results at 24 weeks, which were very much similar to the pegylated interferon. But if you add on pegylated interferon and see the response of triple therapy, the response rate was much better. So this is another study, and this is a recent study, and we contributed to this study, and Dr. Saeed was the principal investigator from Pakistan, and we also contributed to that. And this study results were presented at EASL this year. There were 4 arms. One arm was lonafornib with ritonavir, lonafornib with ritonavir and pegylated interferon alone, and placebo. We can see that the response rate of triple therapy was much better than placebo, and the response rate was better than the lonafarnib with ritonavir alone. But if you see the results, composite results and other results, this was composite response were achieved only in 19% of the patients, though there was more decline in HDV-RNA about 32% of the patients where the triple therapy was used. But there was much improvement in the histological activity index where the triple therapy was used as compared to a dual therapy or monotherapy. These are the other results of the same study that I have already mentioned. And the good thing about this study is that a biopsy was done in all of these patients, and biopsy did show improvement in the histological activity index in the triple therapy patients as compared to the other arms. There was some flares also after stopping the treatment, and these were actually favorable sort of flares, and we heard about these flares in hepatitis B also. Coming to the nucleic acid polymers, are the drugs that block the HBV entry, and they also block the assembly of the delta hepatitis particles. And in the initial slides I mentioned that they prevent the surface antigen from covering the delta virus particles. And these are drugs, this is one of the trial that was published a few years back, in which Rep 2139 was used for 15 weeks, followed by introduction of pegylated interferon. And pegylated interferon was continued for 48 weeks. We can see there was much decline in the HBV surface antigen. In 5 out of 12 patients, surface antigen became less than 50, and HDV RNA became negative in 7 out of 12 patients. And normalization occurred, normalization of ALT in 9 out of 12 patients. But we have this only one study, and further studies are needed to confirm the results in this study. These are the small inhibitory RNAs. We heard about these inhibitory RNAs in the presentation of hepatitis B, and because they prevent formation of hepatitis B surface antigen, and surface antigen is required for delta virus also. So if we can decrease the level of surface antigen, perhaps this may be effective in delta hepatitis also. So 17 patients were in the active arm of delta hepatitis, and 5 patients were in the deferred treatment arm. And we can see there was much decrease in the surface antigen HDV RNA levels. But the problem with this study is that there was elevations of ALT observed in some of these patients, and treatment was discontinued in 8 of these patients. But the patients who continued the treatment, we can see there was much decline in surface antigen and HDV RNA levels. Then we have the pre-S domain monoclonal antibody. This is HH003, and this drug is the drug that acts on the pre-S region of the surface antigen, which covers the delta hepatitis as well. And if you cover this, these monoclonal antibody effectively the pre-S region, then virus will not be able to enter the hepatocytes. So this is a small study, and which shows that in these patients there was much decline in surface antigen and HDV RNA levels. So next step of studies would be carried out soon, and our center has also been selected for this study, next phase 2 study. We heard about antisense oligonucleotide, and this is the investigational drug, and bepirovirsen, which actually prevents the replication of hepatitis B virus and prevents the formation of surface antigen. So if we are able to decrease the surface antigen, perhaps we can also decrease the replication of the Delta virus also. So there are few take-home messages. Interferon standard of Pegylated is not an ideal agent for delta hepatitis. There is limited efficacy in terms of eradication. However, in the absence of any other effective treatment, Pegylated interferon is still recommended, like we do not have bulevirtide in our country. Addition of antiviral agent nucleoside does not improve the response rate, but we do prescribe this with Pegylated interferon to prevent the failure of hepatitis B. Minimum duration of therapy is 48 weeks. Longer therapies may be considered in slow responder. Ideal outcome would be the loss of HDV RNA and surface antigen, which is a goal difficult to achieve with current therapy. We do not prescribe Pegylated interferon in decompensated patients. The newer drug, which is the bulevirtide, in these studies, which is one of the recently published studies, shows that there is improved combined outcome at 48 weeks, and treatment was well tolerated. And this is an ongoing study, so further results of this study would be awaited and welcome. Bulevirtide is now has been approved, and in the EASL updated guidelines for delta hepatitis, this has been added 2 milligram daily. About D-liver study, in which lonafornib with Pegylated interferon and ritonavir was used, and this study again shows better result than Pegylated interferon alone. And further follow-up of these patients is warranted to see the long-term response rate. Small interferon RNAs and antisense oligonucleotides are the other drugs that are being investigated. And however, the problem is when you stop these drugs, there may be ALT elevation and airborne HDV RNA increase that has been documented. Nucleic acid polymers and the newer pre-S1 domain monoclonal antibody, which is HH0033. Further studies are in progress, and we are waiting for the results of these drugs. Thank you very much.